Now that we've discussed the corticospinal tract, the dorsal column medial meniscus pathway, and the spinothalamic tract running through the spinal cord, we are well prepared to talk about disorders affecting the spinal cord. As a brief review, the corticospinal tract runs through the lateral spinal cord, the dorsal column runs through the dorsum of the spinal cord, and the spinothalamic tract runs through the anterolateral portion of the spinal cord, but only after decussating through the anterior commissure. There are in total 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. There are actually more spinal nerves than there are vertebrae. There are a total of 8 cervical spinal nerves. By convention, they exit out of the foramen above their corresponding vertebrae. So, for example, the C3 spinal nerve exits above the C3 vertebrae. However, the C8 vertebrae exits above the T1 vertebrae. In the thoracic and lumbar spine, spinal nerves exit in the foramen below their corresponding vertebrae. So the L5 spinal nerve exits below the L5 vertebrae. Myelopathy is compression of the spinal cord. Myelopathies affect the tracts running through the spinal cord, so there is motor and sensory dysfunction in all myotomes and dermatomes below the level of compression. Myelopathies do not usually cause pain, but they do produce weakness, generally starting with loss of fine motor function and progressing to spastic paralysis and a loss of sensation, starting with the pins and needles sensation, progressing to complete numbness. There is an upper motor neuron pattern of injury from damage to the spinal cord, so after enough time, there is hyperreflexia on exam. Causes of myelopathy include degenerative disc disease causing disc herniation, metastatic tumors, and vertebral fractures. Myelopathy necessitates surgical treatment, unlike radiculopathies, which can generally be treated conservatively with physical therapy and NSAIDs. Radiculopathy is compression of a nerve root after it's left the spinal cord. Unlike myelopathies, radiculopathies tend to be painful. They are lateralized to either the left or the right nerve root, so you see asymmetry on exam. Radiculopathies produce weakness of a single myotome and numbness and tingling in a single corresponding dermatome. Because there is impingement on the nerve root containing the lower motor neuron, reflexes are decreased, so you see hyporeflexia. The most common cause of radiculopathy is degenerative disc disease, which is when the nucleus pulposus in the intervertebral discs bulges out of the annulus fibrosus surrounding it. The annulus fibrosus is weakest at the 5 o'clock and 7 o'clock positions, so degenerative disc disease produces radiculopathy much more commonly than myelopathy. How can we tell which nerve root is being compressed in a radiculopathy? You can tell based upon the distribution of weakness, sensory loss, and hyperreflexia. In the upper extremity, radiculopathy of the C5 nerve root causes weakness of the deltoid and sensory loss over the deltoid. Radiculopathy of the C6 nerve root causes weakness of the biceps, decreased reflexes in the biceps, and sensory loss in the thumb. Radiculopathy in the C7 nerve root produces a weak triceps, reduced triflex reflex, and sensory loss in the middle finger. When C8 is affected, there's weakness in digit abduction and adduction, and loss of sensation in the little finger. The first sympathetic ganglion is close to the nerve root for C8, so on occasion you can sometimes see a herniated disc producing a Horner syndrome as well, presenting as ipsilateral drooping eyelid, small pupil, and absent sweat production. Because the spinal cord is shorter than the spinal column, nerve roots in the lumbar spine have to run inferiorly through the spinal canal as the cauda equina. When a disc herniates laterally in the lumbar spine, it ends up hitting the nerve root, exiting through the foramen at the same level. But when a disc herniates posterolaterally, it ends up hitting the nerve root that exits one level lower. Posterolateral herniation is the most common way a disc herniates. So, when the L4, L5 disc herniates posterolaterally, it impinges on the L5 nerve root. L5 radiculopathy produces numbness over the dorsum of the foot and produces weakness in the dorsiflexors of the foot. When the L5 S1 disc herniates posterolaterally, it affects the S1 nerve root and causes numbness on the lateral side of the foot. S1 radiculopathy also produces weakness of plantar flexion and reduced ankle jerk reflex. Both produce a shooting pain down the buttock and side the leg past the knee. Next, let's go over the different syndromes of spinal cord injury you should be able to recognize, starting with Brown-Sicard syndrome. We have already discussed Brown-Sicard syndrome in the somatosensory localization review, but briefly, it is due to hemisection of the spinal cord and produces ipsilateral hemiparesis, ipsilateral loss of fine touch sensation, and contralateral loss of pain and temperature sensation. To understand the other syndromes, we have to discuss the vascular supply of the spinal cord. A single anterior spinal artery supplies the anterior and lateral spinal cord, including the bilateral spinothalamic tracts and bilateral corticospinal tracts. Two posterior spinal arteries supply the dorsal root entry zones and the dorsal columns. The anterior spinal artery is more prone to infarction than the posterior spinal arteries. Anterior cord syndrome can occur from tumor growth, central disc herniation, or vertebral fractures that compress the anterior spinal artery, causing infarction. The dorsal column remains intact bilaterally, but there's loss of spinothalamic and loss of corticospinal tracts bilaterally. Posterior cord syndrome is less common and usually occurs because of compression, not infarction. There is loss of light touch sensation bilaterally from lesioning to the dorsal column tract, but motor function and and pain and temperature sensation are usually preserved. Central cord syndrome occurs following whiplash, flexion, extension injuries, such as from car accidents. It can occur acutely in patients with pre-existing cervical spinal stenosis in the cervical spinal cord. There is loss of pain and temperature sensation and dermatomes near the injury from lesioning the anterior commissure as the spinothalamic tract decussates. It also affects the corticospinal tract bilaterally, but only the more central aspects. Because of the corticospinal tract somatotopic organization, it produces weakness most prominent in the hands and distal upper extremities. There can also be variable patterns of sensory loss from partial lesions of the dorsal column and the actual spinothalamic tract after its decussation. Another similar syndrome is a pattern of signs from a growing Siringo Marilia in the cervical spinal cord. Initially, the Siringo Marilia impinges on the anterior commissure in the cervical spinal cord, causing loss of pain and temperature sensation only in the upper extremities, described as a cape-like distribution. It can progress chronically to impinge on the corticospinal tract and causes hand weakness.